Good evening. Assalamu alaikum wa rahmatullahi wa barakatuh. This is Abdullah Shihab, Professor of Cardiology and Vice President of Gulf Intervention Society, also the Chief Editor of the new Emirates Medical Journal. It's my pleasure to, with my friends from US and UAE, to host this meeting on, I think, very important and innovation in the field of intervention. You know, we always looking for innovation, but in the right way. And this time is active aspiration. So what was the program going to be as follow? I'm just going to introduce you to the first speaker, give us a technique behind this active aspiration, which is a new technique in aspiration of the clot, which is a big problem when you have a primary PCI. Then we'll show cases from UAE. I think these are the cases first done outside the US. Then we'll go focus more on the cases from US, which is where the more experience. So it's my pleasure and great honor to have both colleagues, one from US, an expert in the field of active coronary aspiration. Dr. Pascal is, I can say, is highly experienced in the field. He's been traveling around the world. He's trained in US and established coronary intervention and structural intervention. He's, I think, done more than 300 these kind of cases, which he's going to share with us. Some of us have done maybe one, some have done zero. But we're going to learn a lot tonight from Dr. Pascal. So we're looking forward to your talk, Dr. Pascal, and please, the floor is yours.
Thank you. Appreciate it. Thanks a lot for this opportunity. So I'm going to start sharing my screen. And all right, perfect. So you guys see my screen?
Yeah, but we don't see the power. Yes, now yes. Okay.
You guys see it? Okay, perfect. So so this is the Penumbra CAT-RX made by the Penumbra. They make a whole range of catheters. So this is the CAT-RX, which is essentially a monorail or rapid exchange. And as you can see, you have the big port through which the aspiration happens, and then you see the wire port. So here's an example floor model. On the left-hand side of the screen is your regular manual aspiration export, essentially showing the trackability, and you can look at CAT-RX as to how well it can traverse through these tortuosities. And I'll show you later on some real-life examples. So the interesting part of this is, if you look at the vacuum or the suction, you can see that it never drops off with the penumbra. It always stays on. Unlike the manual, as the blood is filling up the syringe, obviously your vacuum or your suction power drops down, and therefore there's a risk that some of the clot can get left behind. And even more scary is some of the clot can get dislodged from the guide catheter, and therefore that can embolize. And that's why we've seen in the US, the total trial, there wasn't a whole lot of clinical benefit, but there was actually, in fact, a slightly higher risk towards stroke. And we think it's possibly this clot getting dislodged from the guide. And when you compare it to the rheolytic, which is the angiojet on the left-hand side, you can see the suction power is way more higher with the CAT-RX, which was actually, even I found it surprising. And then they tested this on the bench model, and that's how they found it. So here's a very short study they presented in 2019, essentially a case series of 59 patients from 2017 to 2018. It was a retrospective analysis. And they found that they achieved 93% of them managed to get TIMI-3 flow. And finally, post-procedure, they were able to achieve good results. The mortality at 10 days was 1.7%. But the key thing here, I think, is there was absolutely no incidence of stroke. And when you look into the procedural details, you know, anytime we get a new device in a STEMI, go in and get out quickly. And here's the highlighted ones, the mean time you spend as well as the median time. So as you can see, you barely go up to 1 or 2 minutes. So according to me, it maybe adds like 3 or 4 minutes, and I'll show you with some case series as to truly how beneficial it is. So this is just a very brief introduction, and then now I'll let Professor Abdullah take over and let me know what to do next.
Thank you very much, Dr. Pascal. I think I'd just like to remind the attendees, so far we have 92 active. I think we've heard that more than 400 registered for this. So please write your comments, your questions. You know, this is going to be tackled the last half an hour. So I'd like to share with you a very simple case here, which was outside of, you know, US, they say it, you know. So this is the first case. The story behind this was really funny because we had the colleague from Penumbra and the Life company were coming to me and say, you know, why don't try? And you know, the problem is, we all know about the primary PCI is the best, you know, management, but we don't know why we're not getting, you know, people still having no reflow, having reinfarction while they're in the, you know, we're not getting a good results. People still having mortality, morbidity. So we know this concept of theory behind it. We know we need to sometimes look at resolution. That's so I think this is resulted in these guidelines. We all know it used to be everyone should do aspiration. Remember, Allah, I remember these kind of videos. You know, we just tried this manual one. Then what happens? The more data you have, you know, then you have more understanding and how humble you become. This happened to drug eluting stent and to everything in life. You know, the more information you have, the better. Maybe the technique was wrong. Maybe the device was wrong. We don't know. But you know, this is at the moment is not for routine use, the manual one. But the good news, we have something different. So I want to share with you. So I was convinced to do, you know, I said, look, guys, I don't know when I get a primary PCI, but with the good thrombus. But that day, they were waiting. They're about to go. And then I heard this patient coming with 50 years old, on and off chest pain for a few days and getting worse. And really, ECGs, you know, we can see, look at it. Doesn't look that, you don't know where the problem is. It anterior? Is it inferior? You don't know. I mean, or something. And so what I do here, you know, because something was going here and something, you know, maybe going in the, you know, inferior. So I thought, let me look at the left side. And we look at the left side, you can see the CTO of LAD and, you know, also problem with the left circumflex. So to me, this is not the acute, you know, and I said, I'm not, you know, I looked at the right okay, still the left side. Then we look at the right side and you can see that was the lesion. So that was the culprit. Wired it and you can see still, you know, thrombus there. So I said, guys, you know, you are lucky, or maybe I'm lucky. Let's try your device. This here we started the first time. I never tried this before. This is my first, so don't, if you have any critique, is that you know, my first case. So you see, you know, the way I do it, the way I used to do with the manual one. So went down, even as I think Dr. Pascal going to tell you, you know, it's very, very, very safe device. Actually, you can go down as much as you like, very easily handle. Because I've heard this used in the brain. So when you use in the brain, you are happy. You know, you can use it anywhere. So after this aspiration, we know where the lesion is. But not only that, there is another lesion here. So maybe that's the culprit. Maybe this one is something else. But again, remember, this patient is diabetic, patient is hypertensive, dyslipidemia. We don't know much information about the patient. You got CTO, LAD, you got LCX. Maybe it's not right, you know, to treat the RCA with the, you know, best what we have. So what I normally do with these cases, because I don't know their adherence to the medication, I treat them with the, you know, DCB, which is drug-coated balloon. But anyway, so prepare the lesion here. You know, you can see with the normal balloon several times. You know, then I really applied the DCB below, and it was like, I think 2.5 by 30 distal and 2.75 by 40 at the top. So it's not a bad result for somebody maybe go for a bypass, you know. So this is what. So, but really, I found it beautiful. This device was, you know, and this was the results at the end. This is the RCA, and you can see collateral to the LAD, and that was before. So the enzyme came down, and even the ECG has improved. So what I was trying to say from this case, actually, which is very simple, very easy, is somebody never used this. It found it very easy to handle it and go as distal as you can and get the result and get what if the problem is, and made my life easy that day. So that was my case. So now is, we'll leave the question at the end, inshallah. So now is my pleasure to introduce you to my colleague and friends who is, do everything new in the UAE. I think whole Middle East is from Qasim Hospital. Dr. Wael Abu Shaqqa. Dr. Wael is a great interventionist cardiologist. He's done great cases and going to share with us his experience from UAE. Dr. Wael, we're looking forward to your talk.
Thank you, Dr. Abdallah, for that, for this introduction. Really, you're giving me a push always. Today, I will present 3 cases. Can you see my screen now?
Yes.
Okay. But first of all, I will go for a moment on the concept with thrombus presence in acute coronary syndrome. What we know, and I think everybody here, that the cornerstone for the pathophysiology of ACS is thrombi. This thrombi might vary from minute thrombi that you even cannot recognize by angiography in case of ACS, unstable angina, to large occlusive thrombi. But as you mentioned, Dr. Abdallah, and I think most of our audience and our colleagues know that in 2013, the manual aspiration gained good place in the guidelines, and it was considered a class 2A, and everybody was using it. And in 2015, 2017 guidelines, they dropped to class 2B. And really because the data was not very good, and there was no difference in the results between just doing normal PCI and doing aspiration. Although anybody who does a lot of primary PCIs knows that in the presence of a big thrombi with a TIMI thrombus score more than 3, it is preferred to use thrombus aspiration. But the technique of aspiration is not different. It's different from one intervention to another. So, and as Dr. Bhaskar mentioned, the power of aspiration, it drops significantly after the first few moments of applying the negative pressure from the syringe. And before that, we had the angiojet, which is an old player that did not deliver what is expected because of the crossing profile. We never had a really good results from the trial or evidence-based results that can support us to use it a lot. But today, really, we have this new player in the field. And anybody who's doing a lot of primary PCIs in a primary PCI center, I think it should know about it. So this Indigo Qatar X system, it's really the profile is great. I will show some cases that even with manual aspiration with either the Pronto or the other one from other company, it is not that good for the crossing profile. And I think that the key here that the company started with intracerebral aspiration. So they have the know-how to do a very nice profile. Maybe that's why I was thinking about it. So it have a very good trackability, enhanced durability, and the aspiration power, because it's a motorized, it's really good. I will not go through this, but the most important for me is 6 French compatible. Although I've used it in bifurcation cases with 7 French, you cannot put in a 6 French 2 wires. So if you're gonna do bifurcation, I would recommend to use 7 French, but it is 6 French compatible, and it is a rapid exchange system. So our first case, as we are in the COVID era, so I said I thought about presenting one COVID case. He's a 36-year-old male. He doesn't have any risk factors. He was admitted to another hospital, actually because we are a tertiary center, and we have we are a clean hospital. We don't accept COVID cases, but unless they are coming to have a certain procedure and go back. Another hospital called us. The patient developed ST elevation MI, and he was so we accepted him for primary PCI. His ECG was typical for ST elevation MI. Ejection fraction was really low. It was 35% for a patient who developed ST elevation MI in hospital, and time of transportation was very short. So that's his angiography. The right coronary is normal, but you can appreciate that this sluggish flow, the blood is, since it is some kind of this cytokine storm and increased thrombogenicity. And even in the RCA, you can appreciate that the blood is really although good myocardial blush, but the blood is sluggish, very sluggish. And here's the LAD. And the LAD also, it is not typical form of MI. And we'll see the other cases. It is like thrombi everywhere. So we managed to wire. I think the wire was in a diagonal branch, but no problem. We managed to wire. We passed a balloon. It was passing, but I didn't really. I was not very enthusiastic to go for ballooning, because I thought this was pure thrombi. The patient is not an atherosclerotic patient. So we went with, I chose to go directly because the thrombus burden was big with Indigo cataract system. And usually even with the manual, I don't inject, at least I go for 5 complete rounds with aspiration catheter, keeping it at the site of occlusion for a couple of seconds, maybe 15 seconds or more. And here we have a nice artery, and we did not even stand this with. And we kept him on anticoagulation, low molecular weight heparin for a couple of days, and he would stand back in less than 12 hours to the other hospital. The other case is actually a 44 years old male. He have all the risk factors. He presented with an inferior MI. I've chosen this case because it will show the profile of the Indigo RX cataract X system. His left system was okay. There was nothing significant in the LAD or the LCX. Although there's some intermyocardial bridging in the mid-LAD, but this will not make any difference now. So in this case, because of this angle in the proximal RCA, I was a little bit worried to go with the Indigo RX system from the start. Anyway, we tried to wire. It was really challenging to wire through this big thrombus, but at the end we managed to wire. We done some ballooning just to see what is happening. Although I don't like to balloon because that's when you embolize usually, but I was not very sure because of the guiding support, if you can recognize it here. The guiding was not that supportive, and the patient was not stable also. He started going into hypotension. So we ballooned a little bit also here. But it is the more you balloon, the worse you get in such kind of thrombi. We started 2B3A intracoronary, and I thought I will give the CAT-RX a chance here. And you see how nice it crossed with this bad guiding support. I didn't really I didn't believe it will cross. I thought I will use and it will not cross this angle, but it crossed nicely without a resistance, without minimal resistance. And after a couple of runs, we had a TIMI2 flow. The patient, we give some inotrodopamine and fluids. The patient started to stabilize. I didn't want to stent at this point or more ballooning. It would end up by no reflow, and all of us know what happens when no reflow occurs. You might lose the patient. So I kept him on 2B3A for 48 hours. We got him back, and the thrombus was much better with 2B3A and anticoagulation, and we stented. But unfortunately, I don't have the second angiography after the 48 hours. But the message here is how the profile of this system, the profile is really good. That's what I want to deliver. The third case also is an infrarotary MI case. This is a left system. There's it's good, no disease. And here we have this PLA occluded with a big thrombi, although it is a distal. But also in this case, I'm presenting it to show how the profile of this system. We managed to wire. I usually use hydrophilic wires. I like the Sion Blue wire. Also, Boston guys have a new family that's really nice also, but still I'm sticking to Sion Blue. So we wired, we started using the Indigo system, and it goes really distal. And here we found it was bifurcating. It was very clear, even from the left side angiography. It was filling retrograde, and it was bifurcating. Then I thought, why not also to wire the side branch and try to aspirate from it also. And that's what I've done. I hate losing side branches. I don't know why, but. And this is the final result. So the really good thing about this system that it's the first a motorized system with a good profile. In conclusion, it's very early for us. Maybe you guys in the States will have much more experience for sure. But here it's early very early for us to give a proper evaluation. But the early experience is very promising. We need more evidence-based data from multi-center trials to support our practice. Sure, the presence of such a system in your cath lab makes you work more comfortable, and especially if you are practicing in a high-volume primary PCI center like the center where I am. This is Qasimi Hospital. We are a primary PCI center for mainly for the whole Northern Emirates, and we're doing more than 800, around from 800 to 1,000 primary PCIs per year. So we are always concerned about the thrombi, how to manage the thrombi, because it's an everyday practice for us. Okay, thank you everyone.
Great. I think while that really goes with what's happening in the field of COVID and the thermogenicity of this virus happening to the coronaries and the other vasculature of in the body. So nicely demonstrated, the value of this device. Now we're going to spend 34 minutes with Dr. Pascar taking us through the cases, and looking forward to your cases, Prof. Unmute, please.
Thanks a lot. Appreciate it. Is Dr. Weil still sharing his screen?
Can you stop sharing?
Yeah. Okay.
Thank you. Thanks a lot.
Also.
And I think both of them are very interesting cases. And I think you guys have touched on all the key points. So in the US, as of now, we are currently doing the Cheetah study, which is actually prospective, single arm. It's mainly to see the safety, risk of stroke. So they plan to recruit close to 300, and we are one of the centers. And I think hopefully they should be able to publish some preliminary results. So what I decided was I'm going to present completely case-based and show you where I've used this catheter in different scenarios and how it works in complicated cases, straightforward cases. And also with each case, I want to highlight a different virtue of the catheter. So first of all, big question, why do we need to use a penumbra? So here we have a 55-year-old with an anterior STEMI. So it was done in my hospital. And as you can see, the LAD, there is occlusion at the ostium. The RCA wasn't too bad. So they went ahead, they ballooned it, and guess what happened? So all the thrombus embolized into the circ, and you never know what could have gone into the brain. So finally, this case was successfully resuscitated with the penumbra catheter, and we were able to achieve good flows after fixing branches after circ had some thrombus embolization. So good reason we have to pull out the thrombus if it's a large amount till we have good randomized studies. So what's the big advantage of this? So here's a case of a 46-year-old with an inferior STEMI. As you can see, it's a dominant circ, which is occluded. Important, as soon as the CAT-RX comes out of the guide, I would turn the aspiration on and make sure you got all the 4 bars. I advance it slowly at 1 millimeter per second. And then usually once I reach the clot, I kind of leave it there, let it simmer there for 7 seconds. Best thing is to leave it there, just go around the table and come back. And this catheter tracks very easily, as very well pointed out by Dr. Abdullah and Dr. Weil. So, and also this catheter tells me once I get resistance, as you can see in the second video, how my guide is being pushed out. So it tells me that's the lesion. So usually what I do is I pull back into the patent lumen. I try to build up more aspiration. And once the blood is flowing back good, I go back in again. So you don't have to take it out completely. As long as you're flowing well, you've taken the clot out. And eventually you can pull the catheter out. But when you're pulling, it's very, very important not to turn off the aspiration because you want to catch all the clot. And once the catheter is out, the most important thing you have to do is you have to open your TUI and clean it up very well because clot can be stuck in the guide tip. guide, the hub as well as the 2E. So here's where we aspirated. You can identify the lesion. And then this was a straightforward single stent. We were done. So if we didn't have it and you ballooned it, you'd have sent clot into the two branches. You'd have made a simple, straightforward single stent PCI into a bifurcation PCI. So here's a case where a 45-year-old lady comes in with an inferior STEMI with all those issues. So nasty proximal RCA occlusion. Right? And then as you can see, my partner did this here. We advanced the wire, and then the catheter here, he's advancing a little bit fast, but still you can see how quickly, how easily it tracks over. And once you aspirate it, and here you define an ulcerated, really ugly looking calcified lesion. And also if you notice, we're not using a 10 pacer. So whenever we used an angiojet, we always had to use a 10 pacer because you embolized a lot downhill. And this is what we aspirated. So this was a big calcium chunk there, as you can see. And then above some red thrombus, which we also pulled out from this patient. So, and this was the final finish. We put in a nice 3-5 stent with a great result. Okay. So here's a case, a 70-year-old who actually undergone diagonal PCI, was switched from ticagrelor to Plavix because she couldn't tolerate it. So prox LAD completely occluded with the stenters. So they're able to wire the lesion pretty good. And as you can see, my CAT-RX catheter is through a newly deployed stent. This stent was deployed like 3-4 days prior to this procedure. No issues. So once I aspirate, I got TIMI 3 flow, patient is stable. This is what we aspirated. And then we did an IVUS, So with the IVUS, I realized that, there wasn't really any mechanical defect except for the stent was landed in an unhealthy segment proximally. So we went ahead and finished the PCR with the bifurcation style. This was the final IVUS run, showed the stent was well opposed, well expanded, good results. So this study illustrates that you can pass it through a newly deployed stent, and so far we've not had any issues. So here's a patient actually whom I did this Saturday. So 72-year-old guy with COPD who's otherwise in good shape, had a witness cardiac arrest at home, got CPR, finally got here, some more CPR, and the guy was in cardiogenic shock, sky state. So immediately I put the Impella CP in, but before that I did a quick bedside echo, biventricular dysfunction. So as you can see, the left system's okay. There's the RCA, okay? And went ahead and did the penumbra. As soon as I did the penumbra, that's the advantage which Dr. Abdullah described. You can define the lesion, so you can go precisely and fix it. So as you know, in a shock state, this guy is sick, put the Impella CP. The fact that I don't have to put a temp pacer in, saves away another 5-6 minutes. And everybody knows in cardiogenic shock, literally every 30 seconds is like a year. So we did this, we direct stented it. But before that, we put the Impella right too. And then left a swan catheter because we had TIMI 3 flow, nothing to worry. Then went ahead and direct stented it, and then we got a beautiful result. So this patient is doing well, thankfully. Now here's a case where a 25-year-old gentleman presented with an anterior ST elevation. And as you can see, the LAD is kind of occluded in the mid and distal segment. So here I take the penumbra CAT-RX, do one run, we get some flow, not satisfactory. And despite which we're able to pull out this from this gentleman. And you can see my CAT-RX is all the way down into the apical LAD, which is barely a 2-millimeter vessel. And again, you can, your guide is not backing out, the wire is stable, you're pretty safe. And so far, no pervs, no dissections. So what I do in this is I put my CAT-RX all the way down. And this is not something which the company endorses, but what I do is I open it up, I aspirate, make sure it's flowing free. And if you want, you can inject Cardine into it or nitroglycerin. And just over the weekend, I injected some TNK because the clot was very resistant. And then after you do that, you can inject dye and pull the catheter back. So when doing so, you can actually define the lesion, the problem, without injecting a lot of dye from the guide. And therefore you still maintain wire access and define the problem. So that patient, I didn't have to do anything, good flow, he recovered well. probably was drinking, and he must have had atrial thrombus, which fired into the apical. So he was a 68-year-old who underwent a bypass, had pretty bad EF. Post-bypass, he wasn't doing well. He went into cardiogenic shock. His EKG shows anterior elevation. So put an impella in. Here's the picture. Lima occluded right at the anastomosis. So obviously it was a mechanical issue. Probably the surgeon was pretty aggressive and put a stitch or two extra. So here we went ahead and I used a support catheter and I tried to wire it. And it was tricky. It wasn't an easy cross. So finally we were able to wire through the lesion. And then I put a little micro catheter, inject them really inside the lumen. Good, I'm happy. Then I did an IVUS to find where the problem was. And it looks like there was a lot of shadowing, so maybe a stitch or two extra. And I could see some thrombus, as you can see in the far right-hand lower corner of your screen. So what we did was we passed the CAT-RX. And as you can see, the CAT-RX can cross the pretty easily with no issues. And then this was the picture after the CAT-RX. So define the lesion, where the problem is. I talked to my surgeon, with no problem stenting it. So we went ahead and stented it. And this was the result. So, and again, pretty easily done, quick. Took me about, the whole case took around maybe an hour or so, but with good results. So again, this case illustrates you can put it through a Lima. Again, Lima is a very sacred artery. You don't want to dissect it. You don't want to cause an injury. No problems advancing it. And also through that anastomotic stenosis. So here's a 45-year-old guy who had a stable metastatic colon cancer with inferior STEMI and he had a V-fib arrest. So comes into our lab. He's got a non-dominant right, and you can see his circumflex is probably the dominant vessel occluded in the mid segment. So here we go in, we wire, then we go ahead and perform one run of CAT-RX, and then the picture after that, start to get some flow back, not happy. So I go back in again, do a couple more runs. And as you can see, my RX catheter is way deep down, all the way at the base of the heart. No issues tracking through that. And then I take a picture and we start to get some flow back. So I get a PL division back. But knowing this is dominant, I knew that he had a PDA too, which is coming off the circ. So the good thing is you can inject with your CAT-RX and then you can kind of define the lesion. So I had rewired into the PDA, aspirated. So I got the PL back and there's the PDA. And again, I saw some disease up there. So went ahead and performed another run of RX and then took another picture. And I really didn't see any disease. So went ahead. And this is what I pulled out from this gentleman. So it looked very odd. I sent it to the lab and I'll tell you what it was. It was really surprising. So I did an IVUS to see what really caused this. And IVUS looked neat. Intima was intact. No plaque rupture. Endothelium was perfect. And it turns out this patient actually had MSSA endocarditis. So we did a TEE. He had a vegetation sitting on the aortic valve, which embolized into the coronary artery. And eventually he got his surgery done too. So the other thing we've been doing is in this COVID cases, we all have learned that there's questionable endothelitis proven on some studies. So we are sending these specimens, what we get through Penumbra, to the lab to see if this is a different kind of thrombus, the way these patients react to COVID. So here's a 22-year-old lady who came in with chest pain 6 weeks postpartum. And obviously she had a spontaneous coronary artery dissection. There's a lesion. And again, most of the largest series published in my Mayo. And the data on how to treat this is all over the place, from stenting to ballooning to surgery, and it changes. So what we did was we went ahead and did a Penumbra run. Unfortunately, I've not captured the actual Penumbra growing, but this was after the Penumbra. And as you can see, we were able to restore TIMI3 flow. No issues going through it, And this is what we pulled out. You can see it's a straightforward, short, red thrombus. It was like a cast kind of reference with your 3cc syringe and your catheter there. And we did an IVUS. And when we did the IVUS, you can see from 12 o'clock to 6 o'clock soon, that's where the patient had the coronary artery dissection. And here it comes along and you can see the thrombus. So no calcified plaque. So what we did in this patient was essentially left him on integrilin GP2B3A infusion and brought the patient back the next day and took an angiogram. You can see the arteries completely clean. So we didn't have to balloon, which if you balloon, you irritate it more. You can propel the dissection. You definitely don't want to send a 22-year-old to a bypass. If you really need to, you need to. And we didn't have to stent. So, and she's doing well so far. Here's an example how this catheter behaves in an elderly patient with a very tortuous artery. 97-year-old in very good shape, came in with an anterior STEMI, and after talking to the family, they said, let's try something. She was in pain and she was unstable. And this is one patient where we had to put a temp pacer. So we took a picture, as you can see, LAD occluded at the Austin. So we went ahead and performed a run of Penumbra. I think it's important to know that you may not get a great result right at the first run. I think you do a first run, follow the technique, make sure the blood's flowing back, then reassess, see what the problem is. You see another clot, I would still go back in again, because ballooning might be a very natural, instinctive thing for interventionalists to do. But we've seen that every time you balloon, it's clot, it's going to go downhill, and you'll never know where the lesion is. So we performed it again, another run, as you can see, going all the way, tortuous. Took another picture, and we defined where the lesion was, went ahead, stented the proximal, and then we took a picture. So there was some more clot left, and guess where it went? Right into the diagonal. So rewired it, did another run of Penumbra, and this is what we pulled out. So little bits and pieces of these clots. And some of them I've seen, they're not just thrombus, they also have atherosclerotic material. And unfortunately, I don't think your GP2B3A or even intracoronary TNK is going to fix it. So we went ahead. This is the result we finished off. So did great. You can see the patient's less tachycardic. And you can see the pump squeeze also was looking better. So 97-year-old, no issues, and had a great result. So this is an interesting case. So a 58-year-old gentleman with an infralateral STEMI is a bypass patient. These were the pictures. As you can see, patient actually had a REMA to the LAD, a LEMA to the marginal, and the native disease. And the problem was obviously the graft going to the RPDA and RPLB. So passed the wire, no issues. Did one run of Penumbra, aspirated, and I took a picture, not significant improvement. And usually I start slow, make sure that I don't advance the catheter too aggressively. I know it's pretty easily trackable, very soft tip, but you want to just test your first part and see. And then I knew what was happening here, so I went in for a deeper pass. Sorry, there you go. Yeah. So when I did a deeper pass, and then you see I got flow into the PL, but the patient still had ST elevation in the inferior, and he was still having chest pain. So went ahead and took another picture selectively through the catheter. I defined where the lesion was. As you can see, it's in the distal segment of the vein graft where the ulcerated plaque is right here. And as you can see, the PDA division has a thrombotic meniscus sign. So you can actually park your penumbra catheter there, and you can rewire with your penumbra catheter. So it actually acts as a support catheter from my perspective. So I was able to pass it, and then you can still keep your aspiration on and you go in. So you don't have to take it out, try to wire it and go back in again. Leave it there, rewire it, pass the catheter, do it slowly, and then finished it, and this is what we pulled out. I want to make a very important point. Some of this clots was actually stuck in that tubey. So that's why very important. After you finish aspirating, make sure the aspiration is on till you come out, and then make sure you flush the guide and the tubey, because this is the clot I pulled out from that. And obviously, if you don't pull it out and you inject, it's going to go straight into the coronaries or the brain. So just wanted to show you that. And then after the aspiration, we restore flow. And now, you can take your time, look at the lesion and fix it. So ST segments went down, patient felt a lot better. And eventually this, we put a filter in, and then I did a PCI finishing up the distal RCA. So the 81-year-old guy with a bad EF who did not want to go through surgery, had a pretty nasty, calcified ulcerated prox LAD lesion going into the left main. So because his EF was low, we said, let's go ahead and do a high-risk PCI. So we went ahead and put this patient on an Impella. What we do is we do a single access with the Impella. So the same axis, I put the guiding catheter right next to it too. And I used a long guide just to get over this tortuosity. So put the Impella in. We went ahead and started the PCI. It was very tricky to even just get a micro catheter across. So that is a turnpike spiral. I had to go ahead and perform rota. So we went ahead and did the rota. And the rota went pretty smooth, but then we developed no flow. So when you see that one whole segment missing, it's always, things start to become a little bit scary. So luckily Impella was there, was maintaining a map of 50. We started up some dopamine levo-fed. So obviously it's a dissection, or maybe it's thrown a whole bunch of clot. So what I did was, I thought it was most likely a dissection. I thought anyway I have to stent the proximal LAD. So I ballooned quickly, and then I went ahead and stented the mid LAD and the proximal LAD. I had a 7 French guide, so I went ahead and put a wire into the diagonal because it was a decent size. And then after that, I still didn't get good flow. Oh, sorry, this skipped through. I'll go back again. So this is the only time when you can advance. Only time when you can advance a second wire and the CAD-RX is if you have a 7 French system, as Dr. Weil pointed out. So here's the main second wire. Here's my CAD-RX going through just stent, which I just deployed. No issues, no problems. And then go all the way down, suck it out. And then again, I open it up, clean it up, and then I think my presentation is heavy, so computer doesn't like it. So went ahead, and with the penumbra, you see I inject with the penumbra. There's my penumbra. So that I inject, and that helps me define the problem. So there was one more lesion which we had missed, and that's why the patient still had no leaf flow. So we went ahead, fixed that, and then ended up with a bifurcation PCI up top. This was the finish. Patient did really good. He was in fact discharged the very next day. This was actually a Thanksgiving. So here's a case of a cardiogenic shock. A 67-year-old came with an anterior STEMI. So my partner went ahead and did this. You can see this was the lesion we started with. And I personally think there was thrombus here. And even though you have TIMI3 flow or TIMI2 flow, we still use it if the lesion looks, probably ulcerative, doesn't look smooth. I personally believe there's always thrombus. And then also, we don't use it only in STEMI. I also use it in non-STEMIs or anything which I'm suspecting there's thrombus. So he went ahead, he had a just straightforward ballooning and stenting, and the case did not go well. He embolized, patient had a lot of V-fib shocks, and They spent a lot of time. Things didn't look good. They put a balloon pump and sent the patient up. So the following day, I brought the patient back, and I ended up doing a CAT-RX. I sucked all the clot out, and we were able to achieve a good flow with the finish. So again, the importance of aspiration. Yeah, you can never have a randomized study when you have a very sick patient on the table. You think there's some thrombus, but you want to get the case done quickly because he's sick. And I know some countries don't have the impella, they use the ECMO. So I think this illustrates the importance of take your time, 2 seconds, aspirate the clot out. Once you're clot free, then you can balloon or even direct stent it. And I do that a lot. And we put an impella in, and these were the final finish on this patient. So nice, good TIMI 3 flow. And patient did take a big hit on the EF. It dropped down to 25%, but it did recover, not a whole lot, but at least she's alive. So here's a case for major side branch thrombosis. So we take a picture. As you can see, the LAD is diseased, and then the actual clot is in the diagonal, as you can see. And the RCA is a CTO. You can see the collaterals coming out. So go ahead, put the wire in, no problems. Then I go and perform my penumbra aspiration. And then after I do the penumbra aspiration, you can see this flow in the diagonal. But when you look at this picture, it's like, okay, where do I stent in the diagonal? Do I go all the way down? Do I stop there? Do I need to inject more dye? So what you can do is put your catheter there, aspirate, and you see I'm injecting from my penumbra catheter. And this way you can inject a little amount of dye, and you can define the lesion. And that really, really helps. And then after the injection, we went ahead and stented the diagonal and then the LAD, and we got a good result here. So please let me know when I have to stop, because I just have a whole bunch of cases.
Great. I think, we will take just a bit
Sure.
of break here to see this. I mean, this is like watching, action movie. To be honest with you, I cannot go, really focused entirely and really sometimes merge into the case itself. You take us through all the possibilities. One need to think about, how to use this device, and it's all been successful. So the question I think we had from the attendees, I mean, we have 171 so far with us active, and all of them are like senior interventional cardiologists. The question asking is, how's the reimbursement of this in US? Since, you showed us, you can use it everywhere.
Yeah, unfortunately, I'm in a hospital employed position. So as a physician, I get reimbursed, but I don't think from the company side, it's a range. I mean, from the insurance, the hospital doesn't get billed. So, but we're trying to change that. I'm hoping once the CHEETAH trial is published and we have good evidence, I think it should be a no-brainer.
Right. Dr. Wael, one of the questions to you actually from when Dr. Albert here asking the imaging, you've showed us, you've nicely used that device, and then you didn't use, you said patient not for a stent or anything, he's fine. Where's the role of the imaging in that? I mean, I know you guys use imaging all the time, but were you just angiographically, you think you were fine, or did you look also OCT or IVUS on that case, where you aspirated the clot? Can we hear you? Unmute.
Yes, Dr. Abdullah, I love him. I do more than 90% of my cases using an imaging technique, but unfortunately, in the couple of cases, we don't have a lot of cases. It was most of them. It was very late in the night, and we did not use imaging. But Dr. Bhaskar have showed us that the images, the IVUS images after using the Indigo CAT-RX, and it's really amazing. And hopefully for the next cases, we'll do imaging for the next cases. but I've done like 7, 8 cases, and I didn't use imaging in these cases, unfortunately.
So, Dr. Pascal, you also nicely showed us this is not only aspirating, you can also use it to deliver many things. I don't know what things you can deliver through this. Can you unmute?
Yeah, so I think what I inject is typically after I aspirate the clot, I don't like to stent directly. What I do is I believe in reperfusion injury. I know it's a very age-old thing, but I strongly think that if you can give cardine locally through that, or adenosine, or nitroprusside, whatever you guys use, I've seen that the number of reperfusion arrhythmias has reduced. It's just been my personal experience. And also, just in the case I was trying to pull up this time, I might show you guys. I had a gentleman this Saturday, I did it, where I did a penumbra, it didn't help. I went ahead, I sucked clot, it didn't help, still having chest pain. So eventually I left my penumbra at where the lesion was with an IVUS. I knew this was the problem is, and I injected 4 milligrams of TNK. And then I did another run of aspiration, and then I could define the channel. And then I felt confident and I could go ahead and stent. So again, this is completely not, I want to make sure this is something my personal, what I do, injecting through the penumbra. I don't know if the company guys would endorse that. I don't think it's part of the IFU. But again, in medicine, cardiology, we do, half of it is off label.
No, these are great. I mean, until we have a study, of course,
True.
We are all been through different scenarios, and I think we need to share this kind of experience. I think it's great. Dr. Wael, maybe you have a questions to Dr. Pascal on yourself.
Yes. With atherectomy, if you have an MI, Dr. Pascal, you know that, Dr. Pascal, that in calcific lesions with thrombi, it is forbidden to use atherectomy. And do you think it's after aspiration, if you have a good flow, it is safe to use atherectomy in ACS setting? I'll not say STEMI setting only.
Yeah, we actually, when we had this discussion, I think maybe Friday, we had a case where we had an acute MI. We put the penumbra, the penumbra wouldn't go all the way through, so immediately we knew there was a bad calcified lesion. We left the penumbra, let it stay there for a few seconds, pulled out all the clot, took a picture, we could see the calcified lesion. We couldn't pass any balloon, 1.5 balloon wouldn't go. So what we did was we went and put a wire and we did a rota, and we were able to achieve a good result. So with the penumbra, I was able to define the length of the lesion and knew it was calcified. This helped me define exactly how much rota I had to do. And then we were able to finish up. So I think if you have to use it, you have to use it. If you want to get the lesion open, or in some cases like what you did, you saw a big clot, patient had TIMI3 flow, stabilized. You can even leave them in the hospital, let them sit there, get some GP2B3A, come back and finish it up. And I also want to say the place where we are, there's no big tertiary center 300 miles around. So we get a lot of cardiogenic shock. We get a lot of patients who get TNK and they get flown to us. And we have advanced this catheter through very, very small vessels, despite having TNK, have not had any issues. So I would say the profile of this is something like 1.8 or something. So I usually try to stick within a 2 millimeter vessel.
Yeah, the profile is amazing, actually. That's of this cataracts. That's what I feel.
Any complications with this device you've encountered?
Actually, I have so far not encountered any. My rule of thumb is if you find resistance, stop. You see a guide kicking back, stop. No, knock on wood, so far we've not had any stroke. We've not had any dissection or perf. So.
Yeah, you see that's the thing, about the was against the manuals, the stroke business, but it's great to hear that there's nothing like that happening.
I think also, Dr. Abdullah, the key point in primary PCI with the penumbra system, that it doesn't take time to prepare the system. It's not like using robotic or atherectomy. It takes some time. It is very easy to prepare. The only problem actually is reimbursement from the insurance. This that we should work on.
Yeah. And the question is, normally the people ask, how many of these devices, you have to use to get, you can say you are fine, you are safe to use. I don't know. I mean, we are all used to. But do you have any number, Dr. Pascal?
I think for me, because I got familiar with the penumbra when I was doing my vascular endovascular training in New York, Mount Sinai. So I was using it, in the stroke cases and the lower extremity cases. So when I moved to Rapid City, they gave it to me earlier on. I think after 25 cases, you get a good feel for it. I think then you feel confident to do pretty much. I think 20 is a good number if you ask me.
Yeah, yeah. Sometimes during the elective cases, you get some no reflow and this. Any role of that or during that time? Or?
Definitely, I would use it. I think oftentimes you have a very soft plaque and you balloon it and you got a mixture of a plaque. As you can see from my pictures, I've not only pulled out thrombus, half the time I pull out atherosclerotic material, I pull out calcium material, and we've sent it to the lab and we've confirmed it's not just thrombus. So I think I not only use it in STEMIs. In STEMIs in our hospital right now, everybody uses it, from my most senior partner to the youngest guy. And as Dr. Wild said, it's very easy to set up. It's like just a rapid exchange. You connect it, turn the pump on, and you're ready to go. So, and I've used it. I always keep it handy whenever I do any rota cases, so far it's been very, very useful.
You are right. It just need to start the first case. Then
yes,
the rest will be, and you need really somebody to keep you keep on that. Like the friends who I had that day, I'm saying they were really, it's good to have them, with us. And any other questions from you to the Dr. Pascal? I mean, we dealt with most of the questions here we have. I mean, it's very interesting using it in the graft, as you say. That was because that's what most of sometimes the clot and
clot material.
They showed us, again, very safe and very easy to. And it's beautiful. The one you showed us with the, during the pregnancy, that young 22 years old, really saved, because we don't know what to do, and sometimes we just, one of them is not to do anything. but for you, we did something, and beautiful. The result was outstanding. I mean, for young 22, rather staying on lots of medication forever, and it's you kind of.
I think today I got from Dr. Pascal that it was atherectomy cases. Yeah. You should have it on board. I didn't think that it can help a lot in no reflow, and it's even not mentioned by the company. But from real world, it can help a lot. For atherectomy cases, if you end up on no reflow, it can help a lot. This is something really good.
No, absolutely. And other big thing for me in a STEMI is, I want to get in there and get out. So when you have to use an angiojet, you have to put a temp pacer, or you always are worried. So for me, only time when I put temp pacers, they're already bradycardic and they're not well. In fact, the cardiogenic shock I did on this Saturday, by the time I got my impeller, I didn't. So I think any procedure you cut will really help the whole case.
Yeah. Any experience in the peripheral vascular disease? People with that.
Oh yeah, most of my experience with this actually started with the peripheral vascular. So I've used it. First, I was doing a carotid stent, and this patient probably had a soft plaque, and the whole filter got stuck and the patient was actually having a stroke on the table. And then I was able to go and aspirate her. So I have a case of that too. So and the lower extremities, I think, especially ISR, instant thrombosis, or instant restenosis, it's a very, very handy tool to have, especially do an atherectomy, you embolize downhill. Same thing, I go aspirate and then I inject through that. Again, you don't only catch clot, you also catch a lot of plaque sometimes.
Okay. Yeah, this is stent thrombosis, especially when it's really acute, it's really beautiful. Rather than just
actually, also Dr. Abdullah, in the pulmonary embolism.
Oh yes.
In case of pulmonary embolism, it works greatly. It's very.
Our colleagues in the either intervention radiologist or the neurologist interventions, they use it a lot, and that's really handy, to have them there with you and their experience, and they say, why not using it in coronary? And really the result, as I said, from my first experience and Wael's experience here, and you showed us, the potential. You can use it everywhere.
It was the same because I do a prefer also, and I was wondering why we are not having it in the coronary. So when they got it in the coronary, I was really happy about it.
Interesting. So as a question here, I think I have is, how do you target the patient to use device? Is it for all? No, I mean, we already answered this. I mean, what sort of MI? I mean, any clot to use it? I mean, certain clot you think is better because again, you don't want to, because the reimbursement ideas. Do you use it for everything?
It's very tricky, and I'll be honest, because I am hospital employed and I'm going to get paid. If I was running my own business, it's a different story. So I've period. This is my first go-to device whenever I see there's a thrombotic occlusion. I know I pull out most cases, you get the you pull out and you at least get some flow through, you get an idea of the lesion, you get TIMI3 flow, then you can IVS it. So I think when you're starting to use it, my suggestion would be pick your STEMI case. This is a meniscus sign, you have a nice thrombotic lesion, you're going to benefit from that. Because, to the hospital, the discussion is, if you don't pull the clot out, you're going to balloon and you're going to embolize and there'll be no reflow and the patient stays in the hospital longer. Otherwise, you can get them out in 2 days. So I guess that's the only thing I can say.
Yeah. Dr. Wael?
I think that in any case that you would think about using an aspiration device, if there's no financial issue, I would use the cataracts. Once I will think about using aspiration. So, and I have comparing it to the manual aspiration. No, it's better than the manual aspiration if there's no financial issues. But sometimes word is not, I want to use it, but there is issues that doesn't help. And I think that this will be sorted out in the future. Once we got any agreement with, so this logistics, then the numbers will be much more. I think everybody, as Dr. Pascal said, everybody is now in his cath lab using it for primary PCIs. So I think that's what it will end up like that one day. From my small experience, I don't know, but from the case we saw today with Dr. Pascal, it proves that my feeling was right. That's what I can say.
Yeah, I mean, in theory, it really makes sense, and that's why the manual came onto practice. But then when you put in clinical trials, that failed. But we know the why it's failed because of the reason already mentioned. But this one is different, But again, we need to wait to see the good outcome data to be generalized everywhere. but really, it's really very helpful from my first experience. It was really difficult to want to use it, to be the first to use it outside. You know, it's difficult because everyone's looking at you. You're going to fail or pass that, but it was good.
Courageous. It
was amazing. Everyone watching me. But alhamdulillah, you know, just as everyone doesn't want you to pass. You know, you fail, but alhamdulillah, I passed. Anyway, so that was great, great experience. I think, guys, this was really a very outstanding meeting, different than other meeting we have. You know, the cases we showed is really of great interest and done in a way that's, you know, make it very attractive, simple, but not easy. Simple. Simple doesn't mean easy. Very, very nice, very professional way. Keep the safety and the safety of everyone there. And again, this is a learning curve, as Dr. Pascal says. You need to try it. Area where you feel comfortable, then build up your experience. Don't go for the most difficult one. But again, to have it always with you in the cath lab, otherwise you will not use it. You know, to be there and to remind everyone, you know, let me try it with the, you know, case where there's just, you know, there is a thrombus, and I think that make life easier, and that's where you get experience. Once you get experience, 1, 2nd, 3rd, then life will be easy, inshallah. Any final thoughts from Dr. Wild, then with Dr. Pascal? Dr. Wild.
Thanks a lot, Dr. Abdullah and Dr. Pascal and everyone who worked to organize and make this meeting happen. It's really a very nice and friendly meeting with a very fruitful outcome. I think for me, at least, that was I think I learned a lot today, and I hope we meet in another meeting after some time that we will demonstrate how this impacted our practice actually. And thanks everyone. Thank you.
I want to say thanks a lot once again. I think it was a great opportunity for me, so appreciate the invitation and thanks a lot. Yeah, I hope hopefully COVID settles down, you know, we can all have a real conference, I think. So thank you.
Yeah, really, I'd like to thank you on behalf of New Emirates Medical Journal and you know, the interventionists in this part of the world for, you know, your input. Dr. Pascal really has been great. It was like a beautiful trip and journey through how to use this active device. I think is going to have a great place in our intervention practice soon. And I'd like to also thank Dr. Wael using the innovation all the time in a right way, in a safe way, in a professional way. I'd like to thank the sponsor of today, Penumbra, and the live side from here, from UAE, and everyone behind this. ICOM, of course, make this webinar possible. And all our attendees, we reach, I think, 180 active participants for their questions, for their comments. We learn from each other. I think you are all expert, and you know, sharing knowledge, experience. This is the way we go forward. So stay healthy until next time. Thank you very much.